set the ground rolling for me. Like ma'am has discussed the initial steps and the non-modifiable factors like the age, the egg quality, the sperm quality, which we really cannot control. So what we can control is the ovarian stimulation protocols. So I would be continuing my talk on that. So my objective of my talk would be how to tailor the controlled ovarian stimulation, what are the strategies for the luteal phase in ART cycles, and a little bit about the endometrial receptive area, especially in cases of recurrent implantation failure. So just to brief and just give a brief outline about the types of the ovarian stimulation. We have natural cycle, modified natural, mild stimulation, and the conventional. So in natural cycle, we don't give any medication with the aim just to retrieve single oocyte. Even the modified natural protocol of ovarian stimulation is also the same. It's just that when the follicle is reaches like 16, 17 millimeter, we give HCG so that we can time our stimulation. And in this also the aim is to recover single oocyte. Mild or minimal stimulation, where we give low dose gonadotrophins, either oral and with the adding of GnRH antagonist when the follicle size reaches 14 millimeter, with the aim to retrieve 2 to 7 oocytes, and the conventional, where we use gonadotrophins in high dose and with the aim to retrieve more than 8 oocytes. So the guiding force, like the deciding factors for the ovarian stimulation, is basically guided by the three main factors, that is the age, BMI, and serum AMH levels or the antral follicular count on the ultrasound. However, our main aim is that we should have an optimum response. The stimulations should not cause side effects to the patient. There should be minimal side effects, and with the aim to have a good live birth rate. And based on these ovarian responders, we have categorized the responders at poor oocytes, where we get more than 4 oocytes retrieved, suboptimal as 4 to 9, normal where we get 10 to 15 oocytes retrieved, and hyper responders where we have more than 15 oocytes retrieved. Now, just touching on the basic stimulation protocols, we have GnRH antagonist protocol, we have a fixed protocol and a flexible protocol and a single depot protocol. Now, in the fixed and the flexible protocol, the gonadotrophins are started either from day 2 or day 3 of the cycle when the follicle size reaches 12 to 14 millimeter and the serum estradiol is like more than 200 or 400 picomoles per liter. We start giving antagonist to prevent the LH surge. This antagonist is continued till the day of the trigger. And in the fixed protocol, the antagonist is started on day 6, irrespective of the follicular size and irrespective of the serum estradiol levels. In a single dose protocol, I guess majority of us don't follow this protocol, but yes, followed very widely in the Western world, where on the day 6 of the stimulation, we give 3 milligram, just a single shot of antagonist, which takes care of rest of the days till the day of trigger. Now, that was the GnRH antagonist protocol. We have GnRH agonist protocol, where we have the traditional long protocol, the short protocol, ultra short, and the flare. So the standard treatment is like in the previous cycle. On the day 21 of the previous cycle, the gonadotrophins, either triptorelin or leupride, they are started and they are continued till the day of the ovum pickup. Maybe we reduce the dose once the patient gets the period, and on day 2, day 3, we start the gonadotrophins. The individualized protocols are to be followed and the dose is to be taken based on all these factors that I mentioned earlier. And once the follicle reaches 18 to 20 millimeter, we give trigger and do the retrieval 35 to 36 hours after the trigger shot. And now in short protocol, the GnRH agonist, they are given right from day 1 or day 2, and it is continued till the day of trigger. Along with the gonadotrophins, they are started, whatever the dose we choose to give it to the patient, and the gonadotrophins are also started till the day before the trigger shot. The ultra short protocol. In the ultra short protocol, the GnRH agonist is just given for the 3 or 4 days. The gonadotrophins are started from the day 4 of the stimulation. The gonadotrophins continued till the HCG shot, and the antagonist is added like as we do it in rest of the protocols at the size of follicular size of 14 millimeters. The microdose flare protocol is basically in poor responders where we are using where we are using and taking the advantage of the GnRH analogs. Now this GnRH analogs initially they have a flare effect. So in poor responders, especially where we want the increase in the FSH and the FSLH levels, so that the more and more number of follicles are recruited, we aim to use this flare protocol, this part of the agonist where the GnRH agonists they are given in 40 microgram in a BD, and then the gonadotrophins are given from the day 4 of the cycle. This flare protocol is continued till the day of the HCG trigger. So that was just about a brief outline about the various protocols. Now coming to the advantages of the long GnRH protocol. The synchrony obtained with the long GnRH protocol is very great, is very good. All the follicles that we see on day 2, day 3, they are of very small size. They all are almost of equal size. More oocytes are retrieved, the pregnancy rate is increased, and however, it is suitable only for the normoresponders. The disadvantage of long agonist protocol that there is an increased duration, increased cost, and especially we cannot use it in hyperresponders because of the risk of the ovarian hyperstimulation syndrome. Short agonist and this GnRH agonist protocol usually not much practiced, and I will just skip it. Now coming to the antagonist protocol. This is a very patient friendly. I guess all my colleagues here would agree with me that 70 to 80% of all our cycles are GnRH antagonist protocol. This is patient friendly. There is a reduced requirement of gonadotrophins, shorter duration of stimulation with minimal side effects, and especially they are beneficial in the to prevent the OHSS where we do the freeze-all policy. However, the disadvantage with the GnRH antagonist protocol is that at times we do not see the synchronous cohort of follicles on the baseline scan, like on day 2 and day 3. Some of the follicles may be like a big, like 12 or 13 millimeter, then we are in a dilemma. And probably once the antagonist is initiated, we at times we really need to increase the dosage of the antagonist. Now, all my slides further down, I have compiled up to give you a brief outline of the Eschery guidelines on ovarian stimulation. Though this guideline provides 84 recommendations, I have tried to sum it up as much as possible and considering which are the main practical ones. So each recommendation either a strong or a conditional, and with a grade, these markings high, moderate, low, and very low. So coming to the Eschery guidelines on the ovarian stimulation protocol, especially for the high normal responders or in the polycystic ovarian patients. GnRH antagonist certainly is the preferred protocol by all of us universally, because if we give the GnRH agonist protocol, we have to give HCG as a trigger, which then is the main culprit for the patients to go into OHSS. If at all the agonist protocol is to be used, then the dose of gonadotrophin, we should decrease the dose. It is the recommendation. However, this recommendation is only for the higher responders or for the patients who are PCOS, and this recommendation of reduced dose is not recommended for normal responders. Clomiphene or letrozole probably is not recommended in high or normal responders, and natural cycle is not recommended. Against each, I have given the evidence level, the strong, conditional, and the conditional with the grade of evidence. Coming to the poor responders, in poor responders, the GnRH antagonist works equally good like the agonist protocol. However, this is conditional. At times we see both the pros and cons. We start with the antagonist protocol, we don't find the follicles get stimulated, and in the agonist protocol there might be so much of suppression. But the literature and the all the studies, they point, the meta-analysis shows that GnRH antagonist works equally well as the agonist protocol. In poor responders, like I mentioned this in my previous slide where I had discussed about the hyper responders where clomiphene was not indicated, but yes, in the poor responders, uh, the clomiphene addition of clomiphene to the gonadotrophins is equally recommended, because in poor responders the mechanism of clomiphene citrate, the way it works, that it is a central acting blockage of estrogen receptors. By that the LH and FSH-E2 level increases, because the hypothalamus and pituitary senses that the estradiol levels are low. Via the feedback mechanism, the LH FSH levels, they rise and they lead to increased recruitment of the follicles. So it's a strong recommendation. However, letrozole and addition to the gonadotrophins is not recommended. And now coming to the dosage of the gonadotrophins in poor responders, there are no studies in the where the people have used less than 150 international units. Gonadotrophin more than 150 international unit per day is clear, but the gonadotrophins more than 300 international units per day is definitely not recommended, and this is a very, very strong evidence we have. So in nutshell, if we have to give gonadotrophins to a poor responder, either in the antagonist or on the agonist, we can use the gonadotrophins in the dose of 150 to 300. Now, which LH suppression regime is to be preferred? Now, if we are using the GnRH agonist, which means either the long protocol or the short protocol, the long protocol works better than the short or the ultra short agonist protocol. However, this is conditional. And this the GnRH antagonist protocol works better than the GnRH agonist protocol in the general IVF and ICSI population. This is, I'm talking about the general, and not to be confused with the poor responders where I said that the GnRH antagonist works equally well with the agonist protocol. This is again a strong recommendations. Now, the PPOS protocol, that is the progesterone prime ovarian stimulation for LH peak suppression, usually, especially if we are considering the fresh transfer, it is not to be recommended, because the endometrium receptivity goes down when we start giving progesterones right from the beginning. So it is not to be used in cases of fresh transfer cycles. Yes, if there are donor cycles, we can consider giving progesterone primed ovarian stimulation protocols. Coming to the type of the stimulation protocols, all the evidence, the literature, the meta-analysis have shown that recombinant FSH works equally well as the human menopausal gonadotrophins, HMG, and they work similarly as the purified FSH, and it is a strong evidence. So all of us, we have good experience with all of these drugs, and I guess all the stalwarts sitting here would definitely agree with me that all these gonadotrophins, they work equally well. The only thing where recombinant FSH at times works better, because human menopausal gonadotrophins obtained from the source is the urinary. It is the menopausal women with their urine, it is being made. So at times there is a batch to batch variability. Otherwise, the recombinant FSH, they all work equally well. And the new protocols, the recombinant LH, that instead of if HMG, if we try using the recombinant FSH and we add the recombinant LH, is not recommended over HMG. But again, this is a conditional evidence. Then letrozole or clomiphene as a substitute for gonadotropins in poor responders is not recommended. Again, there is a catch. This is writing as a substitute, where I did mention in the poor responders that clomiphene can be added, but totally as a replacement for the gonadotropins, they are not recommended. Now coming to the pre-treatment, so that we get a good cohort and synchronous follicles on day 2 and day 3. Pre-treatment with estrogen before ovarian stimulation in the antagonist protocol, not recommended. Similarly, the progesterone and similarly the GnRH antagonist delayed start gonadotropin protocol, not recommended. Uh, However, so many of us, we use either estrogens or progesterones to reschedule our cycle, which is quite unacceptable, and it is a good clinical practice point, and it is well accepted. So, I mean, if we are using them to reschedule, the guidelines say they are very well acceptable. However, considering the safety and the efficacy, they are not to be recommended. Coming to the combined birth control pills, 12 to 18 day cycle before the ovarian stimulation, it's a very, very strong evidence that they are not to be recommended. Now, I have a comment to make here, because I presented the same topic on the pre-treatment in Fertivision 2023, just in December, where I did an extensive study, because I use a lot of oral contraceptive pills, contrary to what this literature says. There they gave the viewpoint that if there is a pill-free period of 5 to 6 days, then the effect of birth control pills is washed out. They don't do any harm. And especially, this statement is not to be taken as a generalized statement, because I think 50-60% of our cycles are going as the frozen embryo cycles. Yes, for a fresh embryo start, for a fresh embryo transfer, we can consider not giving the birth control pill. But yes, if there are other indications where we have to plan, where we see the patients from overseas, we need to plan. At times we need to give combined oral contraceptive pills, and especially if the transfer is not planned in the same cycle, I guess it can be considered. Now, considering the use of adjuvants either before or during the ovarian stimulation, I am audible, right? Hello?
Yes, Dr. Shalini, you are audible.
Yes, ma'am. Yes, ma'am.
You are
Okay,
audible.
okay. Yeah. Because I thought I'm just going with that. Okay, so now coming to the adjuvants, we all as practitioners give lot of metformin. However, the evidence says that routine use of metformin in PCOS women is not to be recommended. The metformin use is to be given especially in conditions uh, where the patient is obese, where the BMI is more than maybe 27, 28, where there is an impaired GTT, or there is a family history of diabetes in the patient, or she's not responding to the ovulation induction drugs. Then in those cases, the metformin can be considered to be given, like, because these days ultrasonologists also, once they see the good number of follicles in the ovary, it universally comes in their prescriptions that the patient has PCOS, and invariably we find a lot of prescriptions being, a lot of girls being given as metformin. So are we really justified to give metformin? We really need to relook at that, our protocols. Then the addition of growth hormones, testosterone, DHEAs, especially in the poor responders, are not recommended. Again, it's a conditional evidence. And similarly, the role of aspirin and sildenafil in poor responders are not to be given. But yes, this is a very strong evidence. Now coming to the trigger. Once, do we give the HCG shot? Do we give the agonist shot? Do we give the dual trigger? So the recombinant HCG, that is Ovitril that we commonly use, it works equally well to the urinary HCG, and it's a strong evidence. Recombinant LH is not to be given, and even the 5,000 international units gives almost equal or more efficacious, especially when there is a doubt of PCOS. When there are so many follicles, we can reduce the dose of uh, urinary HCG. GnRH agonist with conventional luteal support and fresh transfer is not to be given. So whenever we are planning a fresh transfer, and we prefer giving the HCG protocol rather than the GnRH agonist, like either the Lupride or the triptolin protocol, which again is highlighted that there is a very strong evidence that in fresh transfer, GnRH agonist protocol with the conventional luteal support, where I say the conventional luteal support considering as the progesterone. So if by any chance, if we have to give the GnRH agonist trigger, then probably we need to supplement low dose HCG, which we start giving either on the day of pickup, like we give 1500 international units of HCG, and which we further continue as in the luteal phase also. And if at all we have to give GnRH agonist trigger, especially in the hyper responders where we are going ahead with the freeze all cycle, we give triptorelin. The dosage could be varied as low as 0.1 to as high as 0.4 milligram. It is a good practice point. And addition of GnRH agonist to HCG as a dual trigger is not recommended. And again, this is a conditional one. So in between there came, we all were giving dual trigger, but somehow my experience also says I did not find any great improvement in the quality. So I have gone back to restricting to as a single trigger. Either I give agonist trigger in hyper responders or HCG triggers in the poor or the normal responders. I'm not combining the two. Coming to the luteal phase support, shall I go ahead? Do we have time? Do I take it? I'll just cut short this presentation.
Because everybody is using the same luteal flow support, so you must emphasize.
Okay, ma'am. Okay. So with the luteal phase, my aims and objectives is like why luteal support, what luteal support, progesterone, what dose, and the role of dydrogesterone. Now, why luteal phase support is must in IVF cycles? Because the supraphysiological steroid levels in IVF, where we have multifollicular development, they inhibit the LH secretion from the hypothalamo-pituitary axis, which causes the luteolysis. It shortens the luteal phase and thus results in implantation failure. Like in agonist cycles, there is a LH separation, and in antagonist cycles, the pituitary, there is an excessive negative feedback mechanism which suppresses the pituitary LH release. And moreover, when we are doing the ovum pickup, we are removing the granulosa cells, which again leads to the corpus luteum deficiency and poor secretion of progesterone. Again, this highlight again depicts the same what I covered in my last slide, that corpus luteum function, it depends upon the pulsatile LH release from the pituitary, and in stimulated cycles there is a period of deficient LH activity. Dose, they can be given either in the oral, vaginal, intramuscular. Oral dydrogesterone, vaginal we have micronized or the natural progesterone or the Crinon gel. And intramuscular, we either have oil-based and water-based. Oil-based is to be given 50 to 100 milligram daily, and the aqua-based as 25 milligram daily. Now, coming to the physiology of the various routes of progesterone, oral is easy. This I'm talking about, not about the dydrogesterone. This I'm talking about the micronized progesterone or the other natural progesterone. That oral, they are easy to take, but only 10% are absorbed because they have first hepatic metabolism bypass, and the side effect is sedation and hypnosis. Vaginal, definitely, because we are giving it locally, the high concentration in the endometrium, target delivery. But the side effects are, many patients, they complain and say that there is a vaginal discomfort and discharge and irritation. Intramuscular, we all know that they work well, but they are very painful. Studies have shown that vaginal is as effective as intramuscular and oral, where I mean the dydrogesterone. Now, when to start? The ideal is to start on the day of pickup. Early start, there is a decrease in the implantation rate because there is a premature secretory change. And if we start later, which means 48 hours later after the ovum pickup, the luteal insufficiency is there, which again leads to the decreased implantation rate. So the acceptable window is 24 to 48 hours after the oocyte retrieval. This point again I'll be covering in my HRA guidelines. So following a fresh embryo transfer, progesterone can be discontinued once a positive pregnancy is detected, because in fresh embryo transfer, the corpus luteum is active, whereas in our frozen cycles, we don't have any corpus luteum. So in those cases, we have to continue the luteal phase support for a longer time. So this is, never ending debate when to stop the progesterone. But going by the scientific evidence, fresh embryo transfer, we can stop it, whereas in FET, we have to continue forward. But I guess most of us don't have the jigra to stop even in fresh cycles once the positive pregnancy comes. Now, dydrogesterone is coming up in a big way, and they have many advantages. Basically, they increase the PIBF cells, the progesterone induced binding factor cells, and it causes the shift from TH1 to TH2, which is a favorable TH2 response. And it is more selective progesterone. It has lower affinity for androgen and glucocorticoid receptors. So this was a Lotus 1 and Lotus 2 trial comparing the dydrogesterone with the vaginal progesterone. Now the Lotus 1 was uh, for the suppository, whereas the Lotus 2 was for the vaginal gel. Again, these were the number of patients. These trials were carried out at 38 sites, long over a period with so many participants, and again proved that luteal support. They concluded that dydrogesterone is as effective as micronized progesterone. They have the potential to induce a paradigm shift for luteal phase support in the estimated 1.5 million women undergoing IVF each year. However, with the frozen embryo transfers, endometrium is totally dependent on the exogenous progesterone supplementation, so more studies are warranted. Now, I'm just summarizing this luteal phase protocols, the HRA guidelines. They say only the progesterone is recommended for luteal support after IVF and ICSI, very strong recommendation. The various doses, natural progesterone by the non-oral routes are to be preferred. This I'm talking about the natural progesterone and not the dydrogesterone. So either it is 50 milligram once daily for IM progesterone, 90 milligram daily for the gel, and 400 milligram 2 times daily for the vaginal pessary. And as a good clinical practice point, as I said earlier, that they are to be given either ideally they are to be started on the day of egg retrieval or till 3 days till the post retrieval if you have given HCG, because HCG has a longer life, and they are to be given till the day of pregnancy test. Coming to the dydrogesterone is probably recommended for luteal phase support, and it's conditional. Addition of estrogen not recommended, and HCG as a luteal phase, especially where we have already given the trigger as HCG, is not recommended. Uh, Way back in 2011 and 12, there was a surge. There were a lot many articles which said that GnRH agonist either in bolus or in reported doses were being given as a luteal phase support, but they are not to be given. It is only to be used only for the research purpose in the context of clinical trials. Just my last topic of ERA, or this like ERA is the endometrial receptive array. This was developed in 2012. Now it analyzes basically the 238 genes. and it gives us whether the endometrium is receptive or not. I'm just quickly going through it. There are various protocols either in the natural embryo or the frozen embryo transfer, but majority of us, we do it in the frozen embryo transfer. We exactly parallel the same way where we would be doing the frozen embryo transfer in the next cycle. So it is kind of a mock transfer. So either it is to be LH plus 6 or HCG plus 7, there is a little error, or on the 5 days plus from the day of pickup, we count it as. Then we take a sample, we send it to the genetic lab, and the report comes as either receptive, pre-receptive, or post-receptive. If it is a receptive, we go ahead with the embryo transfer. If it is a pre-receptive, we give one more day progesterone. Or if it is a post-receptive, we reduce the dose. We reduce the progesterones either by the mentioned in the report by how many hours. So basically, the current status of ERA is basically more in the recurrent implantation failure, and few studies have shown beneficial in that. So with this, I just wind up my presentation, and the forum is, I guess now we have Dr. Sunita. I'll stop sharing.
So we will request chairpersons for this session, Dr. Shivani, Dr. Jyoti Malik, and Dr. Aruna.
Dr. Sunita, Shada ma'am said we'll take the discussion right at the end. So you go ahead with your talk. Yeah, yeah. So